Assalamu alaikum. The clinical day. Mr. John Anderson, 63 years old, with complaint of short of breath for the last 6 months. His saturation 93, pulse rate 77, temperature 36.8, blood pressure 120/75. Please take history, examine the patient, and address his concerns. Can start after sharing the timer. Okay, here you go.
Okay. Good afternoon. I am Dr. Musa, doctor in the clinic today. Let me confirm you are Mr. John, 63 years old.
Yes, doctor. Yes, I am.
Okay, Mr. John, we are here to discuss about your condition. Is it okay with you?
Yes, doctor, please. Yeah.
Okay. Okay, Mr. John, before we start, can you tell me more about your condition, please?
Yes, actually, doctor, I have been experiencing difficulty breathing for the last 6 months.
Okay, I'm sorry to hear about that, Mr. John. So it started suddenly or gradually?
It started gradually. It's getting worse for the last 6 months. I have been experiencing it more and more during the day. Recently, even at rest.
I am very sorry for that again, Mr. John. Can you tell me, Mr. John, this difficulty of breathing worsen with exertion?
Yes, doctor. Yes.
Okay. Can I know how many steps you are walking to develop shortness of breath?
Maybe walking for like 4 or 5 minutes makes me starting to feel it.
5 minutes. Okay. Okay, Mr. John, do you notice anything that improve your difficulty of breathing?
No, doctor.
Like rest? Like rest?
No, doctor. No. Actually, when it started, I used to have good days and bad days, but recently, it's just there. Nothing relieve it.
Okay, Mr. John, sorry for that. Mr. John, are you have any breathlessness when you are lying flat?
No, doctor. No.
Any breathlessness awake you from sleep?
No, doctor.
Any racing heart?
No, doctor.
No. Okay. Any chest pain?
No.
Any leg swelling?
Legs swelling? No.
Yes. Then do you have any cough?
Yes, doctor.
Can I know it is has phlegm or no phlegm?
No, doctor. No phlegm.
No
It's
phlegm.
a dry cough. Yeah.
Okay, sorry for that. Any cough of blood?
No, never.
Okay. Do you have any noisy chest?
No.
Do you have any nasal crusting or stiffness?
No.
Any sinus pain?
No.
Okay. Do you have any headache?
Not that much. No.
Okay. Especially at the morning, don't have, yes?
Sorry?
Especially at the morning headache.
No.
Okay. Do you have any excessive snoring at the night?
Sorry?
Snoring. Do
Snoring? No,
yes,
no.
anyone notice that?
No.
Okay.
No snoring.
Okay. Do you have any long-standing disease? Should be aware.
No, doctor. No,
Okay.
I used to be fine and well. No.
Okay. Do you have any tiredness?
Not in particular. No.
Okay. Any fever?
Yes, doctor. Yeah, I used to have fever at night recently.
Fever. Okay. Do you take any drugs to improve this fever?
No, not in particular. Sometimes I had paracetamol for it, but not regular.
Okay. Any lumps or bumps in your body?
No.
Any lose of weight?
Yes, doctor. I lost about 3 kilograms over the last 6 months.
Okay. Is it intended?
No, doctor. No.
Okay. What about your appetite?
It's good.
Okay. Any joint pain, Mr. John?
No, not at all.
Any back pain?
No.
Okay. Any rash in your body?
No,
Okay.
I didn't notice any.
Any rash? Okay.
Mhm.
Okay, Mr. John. Do you have any dizzy spell history of dizzy spells?
No.
Okay.
You mean being dizzy? No.
Yes, being dizzy. Okay.
No.
Any change on your bowel?
No.
Any change on your water work?
No.
Okay. Do you have any history of blood transfusion?
No, doctor.
Any history of sharing a needle, tattoo?
No, doctor.
Okay. Can I ask Mr. John, are you married?
Yes, doctor. Yeah.
Okay. Can I ask a private question if you don't mind?
Yes. Okay.
Okay. Do you have any problem in your intimate relationship?
No, doctor. No.
Okay. Can I ask, sorry for that, do you have any casual unprotected relationship?
No, doctor.
Okay, very good. Mr. John, can I know any history of hospital admission?
No. Not recently. No.
Okay. Do you have any family history of chest condition or stroke?
No, doctor. Actually, my father died of recently after a heart attack, and my mother is having hypertension, and we had eczema in the family, but I'm not having this. No.
Okay, sorry for your loss of your father. I'm sorry
Thank
for
you,
that.
doctor. Thank you.
Okay, can I know what's your medication list?
I'm not using any medication, doctor.
Any over the counter or
No.
okay.
It's just paracetamol every now and then, and nothing more than that.
Okay, sorry for that. Any party drugs?
No.
Okay. Do you travel recently?
No, never.
Okay. Do you smoke?
Not at the moment.
Okay, so you are ex-smoker.
Yes, I stopped smoking for the last 5 years. Actually, after the death of my father, I just get scared and I stopped smoking.
Drink alcohol?
Occasionally.
Occasionally. Okay. Okay, Mr.
Anderson. John Anderson.
Mr. Anderson, Mr. John. Okay, can I examine you, Mr. John, please?
Yes, doctor, please. Yeah.
Okay. First, I will examine the hand for any clubbing,
No clubbing.
any leukonychia.
No.
For the pulse.
It's regular, as mentioned outside.
Okay, blood pressure.
Blood pressure as outside. It's okay, normal.
Okay. Then I will examine the eye for any pallor.
No.
Okay, then I will examine the mouth for central cyanosis. Then I will see the jugular, the GVB.
Not raised.
Not raised. Okay, then I'll image chest for chest expansion.
Normal, equal.
Normal, equal. Okay. Breathing sound. Auscultation. Vesicular.
Which upper, lower?
Both upper and lower.
Upper, you find like if bilateral crepitations in the upper zones, lower zones normal.
Bilateral crepitation. It is fine crepitation.
Fine crepitation, upper zones, yeah.
Upper zone. Okay. And the lower?
Clear.
Okay. Mr. John, sorry, I will examine the heart for the apex and the B2.
It's normal. B2 not palpable, not high.
Not high. Okay. Any murmur?
No.
Okay. Then I examine the lower limb, the leg for any lower limb edema.
No. None. Normal.
Okay. What do you do for living, Mr. John?
Actually, I'm retired doctor for a year now, and I'm doing my own business. I'm preparing a farm. I'm doing a farm now. Yeah.
Yes. Okay. Okay. What's your job? What was your job?
I was an accountant, an office accountant.
Okay. So now you are in the farm. You are in
Yes, I'm
contact.
constructing a farm. Yes.
Yes, you are in contact with cattle and sheep.
Sheep and trees. Yeah.
Okay, Mr. John. Mr. John, do you have any sweating at the night?
Yes. It's mainly fever. I measured my temperature before. It was 37.6.7, like this.
At the night?
Yes, at night.
At night, okay. Okay, Mr. John. Do you have any weakness in your body?
No, doctor.
Any numbness in your body?
No.
Okay. Can I know what's your concern, Mr. John?
Actually, doctor, I'm just wanted to know what is going on with me, and I'm really concerned. Is it a cancer?
Okay, Mr. John. Mr. John, according to examination, I think you have a bug infection in your lung. And I'm sorry to tell you that it is a severe bug. So what we are going to do, we will admit you in the hospital. We will make some blood tests and also some scans to your chest, to your lung, give you some medication. And we will have another meeting to discuss this result.
Okay, doctor. So I need to stay in the hospital.
Yes, Mr. John, it is your full health.
Okay.
So, according to this bug, it is called botulism. So, I'm sorry to use that it is a severe bug, but the time of we start treatment it is will affect the outcome. So, we will admit you in the hospital now. Okay.
Okay, doctor. Okay.
Okay, Mr. John. Do you have any other concern?
No, doctor. But I noticed that when I'm off work, when the day when I stop going to the farm, I feel much better.
Thanks, Mr. John. Okay, but there is no wheezes. Okay.
No wheezes, doctor.
No wheezes. Okay.
No.
Okay, Mr. John. So it is better to contact our occupational worker. They will, I think, will help you about this issue. I think this condition may be related to your job. So it is better to take some rest from the job and change also your job.
Okay, doctor. Okay.
Okay. Thank you, Mr. John.
Still 2.5 minutes. What you want to examine is Dr. Mahmoud.
Thank you. Or even in the history, if you want to ask more questions.
Okay.
Yes.
Still you have 2 minutes. Yes.
Okay. Did you, Mr. John, please? Is your symptoms improved when you are at home?
Yes,
you are at
doctor.
home? Okay. Did you?
Actually, my wife noticed that. She mentioned like when I'm off, my cough is much more less than when I go to work, when I go to the farm. Yeah.
Okay, Mr. John. Mr. John, did you do any blood test of your lung?
No. What do you mean by blood test?
What is the name? Blood test, I think.
No, I didn't had any.
Okay. Okay. No history of travel recently, yes?
No travel, no.
Okay. Thank you, Mr. John.
Again, it's still 1:20 seconds. 1 minute 20 seconds. What you want to examine, Dr. Mahmoud, please?
Examine heart.
It's very important, and some disease like infectious disease, it might be very important in the mark.
Lymph node, Dr. Basa?
Yes.
Yes, you didn't examine the lymph nodes.
Yes, lymph nodes. There is any enlargement? I will examine the axial and also mandibular.
No, they are normal, all normal.
Normal. Okay. What else, Dr. Bassem?
Yeah, this is my point. Only lymph node in
Yes,
infectious
lymph nodes is very
disease.
important. Yeah.
Yeah.
Yes, Dr. Bassem. Yes.
Okay.
Yeah, give me leaflets.
Okay, I will give you some leaflet and brochure about this disease. Thank you, Mr. John.
Okay. Still, you have 20 seconds and you have chest disease and the whole steps of chest examination you didn't do. So we will stop here.
Yeah.
We will
Okay.
go to the examiner question, but it's advice, I mean. Okay, go ahead to the examiner question. Please, Dr. Najlan.
Okay, can you please present your case?
Yes, today I examined Mr. John. He has difficulty of breathing. Started gradually since 6 months. He has severe fever and fever at the night. He also lost weight. During examination, he is work in a farm, and his condition improved when he was away from his job at home. Examination of the patient, he has fine basal crepitation in the upper lobe of the lung. So my differential diagnosis will be I forget I didn't remember the financial extrinsic allergic alveolitis. Yes. Okay. It is my first diagnosis will be extrinsic allergic alveolitis.
Yes.
And also maybe tuberculosis, and also I think maybe botulism.
So if you can just clarify for me what is with and against tuberculosis and what is with and against botulism. History.
Okay.
What botulism, Dr. Mahmoud, you want to say?
Yeah, what is
You mean
brucellosis?
brucellosis, you mean?
Brucellosis, yes, I mean brucellosis.
Okay,
yes.
go ahead.
Yes.
Okay.
Okay, against TB, it will be no sweating at the night, and also if tuberculosis, it will be symptomatic all the time.
The type of cough, is it going with TB?
Yes, the type of cough. Yes, it will be cough with
productive cough.
productive cough, and against brucellosis, it will be also fever all the time.
No fever in your patient, no back pain.
Yes, no back pain. Yes,
and no,
yes.
and you didn't ask about the history of drinking milk.
Sorry.
Drinking milk, raw milk.
Yes, drinking milk. Yes.
So what else other than what another differential diagnosis you may consider in such a case?
Maybe aspergillosis.
Yes.
Yes.
And what else?
Also
occupational asthma.
Occupational asthma, yes.
Yes. And what about the lung cancer? The patient raised the concern about lung cancer. Would you put it in your differential diagnosis?
Yes, sure.
What with it and what against it?
Yes, with it is loss of weight.
Yes.
And also maybe I don't remember loss of appetite, but against that, and also fever. But against that, no lymph node, and also the patient not a smoker.
He had a significant history of smoking.
Yes, excess
So
smoke.
with it is the loss of weight and the smoking, but against it, no history of spitting blood, isn't it? So yeah. So how would you like to examine, to investigate your patient?
Yes, I will admit my patient, and also do apart from basic investigation, CBC, looking for white blood cells, and also liver function test and kidney function test. Also, I will do inflammatory markers, and then I will do pulmonary function test, especially when he was away from the job and in the job. And also I will do CT to the patient, CT chest, CT and pulmonary function test, and we need also bronchial alveolar lavage, and also I will do acid fast bacilli.
Okay. So what do you expect in the CT?
I think reticulonodular shadow.
Changes of lung fibrosis, isn't
Yes,
it?
change of lung fibrosis.
Yeah. Okay. And what do you expect in the lavage?
The lavage, I don't know.
Okay. So how you will manage your patient?
First, it is by multidisciplinary team, patient education and patient counseling, and also occupational support. And he should avoid. He should change his job, and also I will give him steroid, and also physiotherapy.
Okay. And sorry. And what about this acute management, or what about in the future? What about the ongoing treatment for such a case?
I think in the future he must change his job. I will give advice for that.
Okay.
But I don't remember any treatment.
Okay. Okay. And what is the complications of the extrinsic allergical pholitis? Long-term complication if the patient didn't change his job and continue exposure to the allergen?
Yes, it may lead to respiratory failure, and also may lead to pulmonary hypertension.
There is a condition, a named condition, like a complication of if
pulmonal? No, not pulmonal. Respiratory
bronchiolitis obliterans. Bronchiolitis obliterans. Okay.
Okay, Dr. Nagré.
Okay. Sorry, Dr. Mahmoud, wallahi, بس يعني I studied well.
I the first time I know extrinsic allergical pholitis. It is from the MRCP second part.
Dr. Najla, I have a question. You said it's basal or apical?
Apical.
I guess EEA or
extrinsic
basal, yes.
No, apical.
No, she said apical.
Basal. Yeah, but it's basal. It's not
extrinsic allergical pholitis.
Allergic pholitis is the apical.
Apical.
Are you sure?
Yes.
I studied well, guys. I studied well. That's why this is a problem today. So
it's apical, yes.
Apical.
Okay. You can comment now, Dr. Najla. Start commenting, please.
Yeah.
Using also the marking sheet.
Yeah. So you need to guide me, Dr. Basim. I'm not yet.
Okay. The first is physical examination.
Okay.
Did he examine well?
In examination, Dr. Mahmoud, I feel like you missed. You have the time. You got plenty of time, but I feel like you need to be more systematic in examination. You did well. I mean, like you concentrated on examining the affected system first, which is very good. Like you have to examine the respiratory system
But
first.
he didn't do
need
the
to
full
do it
examination.
in details. Yes, you need to do it full examination of the respiratory system. So I suggest doing from the hand, clubbing, no palmar erythema. Go up straight forward to you did the eyes, the pallor, the mouth for cyanosis. Do the lymph nodes straight away, trachea central or not. Then the chest, do the chest expansion, do all the steps of chest examination until auscultation. You can at least do the expansion and the auscultation afterwards, and then you can go for other systems. So yeah, you miss the lymph nodes, as Dr. Basim mentioned. It's very important in the respiratory case. So
okay,
I will detect some
what else, Dr. Basim? Chest expansion and
expansion. No, from inspection, not only
trachea.
inspection, palpation,
Yes.
and percussion, auscultation.
Yes.
Okay, inspection for scar, the trachea, the
Yes.
shape of
Trachea
the
central or
chest.
not.
Yeah,
Mm-hmm.
the
Yes,
shape
yes.
of the chest. Then palpation of trachea, tracheal tug, if you want, a
Yes.
palpation of the lymph node,
Yes.
expansion at the back, expansion in the front, or
Yes.
you want to
Listening
start
from
front and
front
the
of the
back.
back. Yes.
Yeah, you should do all the steps of chest examination. You have clear chest case,
Yes.
and you have good time. You
Yeah. The
lost.
time was very good.
Yes, you consume time well in the history, and you had a lot to do in the examination, but you didn't do anything. Then you ask the concern. You didn't do examination. So I will give you unsatisfactory. Agree, Doctor Najla, or you want borderline? No, no.
Borderline. Borderline.
We should be. No, no. Listen.
I will be happy, Dr. Nag, no problem, no
But
No,
problem.
no. It's not.
it's
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 okay.
not.
yes,
It's not about. It's about exam, near exam.
yes,
Yes.
So
yes.
we have to teach him, and he should learn from the mistake.
Yes.
Otherwise, he will lose good or a lot of marks in the exam.
Yes.
So I will be little bit tough, Doctor Mahmoud, please.
Sure, Dr. Basim, as you
Okay.
like.
Okay.
Okay. Okay. What
Just
was
to
the
be
category?
okay. The next skills is identify findings. Did he?
Actually, it's very difficult. Like, he didn't examine the lymph nodes. He didn't examine the trachea. He identifies
Okay.
the apical crepitations, but otherwise nothing.
Okay. Good.
Yeah.
He pick up the crackles. Even the crackles, Doctor Mahmoud. You didn't ask. Give me
Yes.
a cuff to clear
Yeah.
it or not.
Yes.
And always, this is another lesson, Dr. Mahmoud. Whenever you have
Yes.
crackles,
Mm.
ask the patient to cough. This is in two stations, in the chest
Yes.
and in the lung.
Mm.
Always I am saying this advice. Any
Yes.
crackles,
Correct.
ask patient to cough.
Mm-hmm.
Just to know, is it something related to bronchiectasis, airway disease, or it's fibrosis and lung disease, interstitial lung disease, right?
Yeah.
Agree?
Mm-hmm. Yes.
Yes, yes, Dr. Baz. But there is a finding in trachea or
I don't
No,
think,
the trachea
but you
will
have
be
to.
yes,
central. The trachea
Yeah,
central because it's bilateral changes.
exactly.
Yeah.
yes,
So
okay.
bilateral fibrosis will pull the lung in the put
Yeah.
the
It
lung
will.
in the midway. It's not
Yes. Mm-hmm.
the mediastinal will be in the midway,
Yes.
central as normal.
Mm-hmm.
Okay,
But
so
it's
I will
very
give you
important.
borderline because you pick up one finding, which is crackles, although you didn't do the clearing.
Mm-hmm. Mm-hmm. What else?
Okay, clinical communication, the history taking, jargon use,
The
or
history.
system approach.
Yes, the history. I feel like he missed. He missed even after he got the farm as a culprit cause.
Uh-huh.
He didn't clarify about the
The
symptoms more during when you are in the farm, the off days, and
not only this, when he was in contact with the farm
yes,
issue, when
mm,
he did start or when did
yeah,
he
when it
start the
started, yeah,
farm construction, you have
mm,
to ask, is it related to the symptom or no?
yeah,
Yes,
yeah, because the patient volunteers that his wife is she noticed that when he's off, when he's away from the farm, he's much better. So this is the key of this case, I believe.
Okay, so again, yes, you took good history, but you didn't roll out most of the important
Mm-hmm.
question. Where is
Yeah.
the GERD as a chronic cough?
Yes, he didn't mention. Yes.
Acid
Yeah.
brush? Always, Dr. Mahmoud, you ask about acid brush. I don't know why this case
yes,
Yes,
particularly you
very
didn't ask
important.
about it.
It's one
And
of
he
the
always
defense.
asks this question. Believe me, he
Yeah.
always asks this question: acid brush for
And
GERD.
contact with
The
patient with cough.
occupational and asthma.
Mm.
Yes, contact with sick patient for
Mm.
TB.
Mm-hmm.
And you give also differential for TB while you don't know any
Yeah.
history of contact.
Yeah. And I mentioned eczema in my family. You didn't
Yeah,
clarify. Do
you
you have
have to.
asthma? Do you have hay fever? Because if you ask me, I will mention that when I was young, I had hay fever, but I'm not having the symptoms anymore. So, like when you pick atopic illness in the
Yeah,
family,
you
you
have
have
to
to clarify
the
the
asthma
topic.
itself.
Yeah, the asthma and the any atopic
Mm,
diseases. Yeah,
yeah,
even
and
allergies to food, certain type of food or something like that. You can ask this
mhm.
question. Yeah.
So this is for the asthma as a top differential. Chronic cough and short of breath asthma, you have to put it in the top
Mm-hmm.
versus occupational asthma
Occupational asthma, yeah.
because it's long duration.
Mm-hmm.
And both of them are valid as differential. You can put
Differential,
it,
yeah.
yes, you can put them in the differential.
Mm-hmm.
However, no wheezes. Okay,
No
but
ways, yeah.
asthma is on and off symptoms.
Mm-hmm.
Even the patient might present with no wheezes.
Mm-hmm.
The occupational also might present with no wheezes. So
Yeah.
they are very good differential in this patient.
Yes.
Okay, agree. So I will give you borderline in the in the clinical communication, in the clinical judgment, Doctor.
Clinical judgment.
Uh-huh.
So, clinical judgment. So, you mean the differential diagnosis here, or
No, differential is different
so the
category.
clinical judgment? I believe you need to. You
Yeah,
mentioned like you should stop work. I believe a referral to occupational health, who they can discuss modulation of your job, because there is option of wearing
no,
mask or
but this is not
neglecting mask.
this is private job, Doctor
Yes, it's a private
Najla.
job, but again,
So
occupational team can give advice regarding how to avoid allergies. So
yeah, I
I
guess
think.
this can be given by the chest doctor. I
Mm-hmm,
think occupational worker, they will be concerned related to something
mm-hmm.
financial, not to his private job or his something doing in his retired stage.
Yes. Mm-hmm, mm-hmm, mm-hmm.
Anyway, still the clinical
Okay.
judgment, he didn't use it well. This is
Mm-hmm.
my point. And he didn't give good explanation to the symptoms and the management plan. So the clinical
Yeah,
judgment,
and you mentioned botulism, and I don't know, like I didn't
yeah.
get that you mean brucellosis, because you mentioned to the patients that you have botulism.
Yes,
I
yes.
Yeah.
Mm.
So, I mean,
So
because maybe because you didn't got like it is related to the farm at that time, but brucellosis, is it is it common presentation to come with cough and shortness of breathing all the time? I'm not sure.
it's it's not common as chest only. It will be systemic disease,
Yeah, yeah,
lymphadenopathy, back pain.
yeah. And it will be like clear contact with milk, like drinking raw milk it will be like
It will be
um
also anaclo,
yeah,
yes.
why, because it will be like yeah, apparent.
Okay, so this is borderline also for clinical judgment. For the differential diagnosis, do you think his differential makes sense about the case? He put brucellosis. Okay, we can say might be related. TB, I guess it's not related
Not
at all
related, yeah.
because he doesn't have any cough up of blood or hemoptysis, I mean.
Yes, and it's not protective cover as well.
Yeah,
Mm.
and yeah, there
No
is
contact. Mm.
night sweat, but no
It's mm-hmm.
symptom suggestive of TB.
Yes, it's common with extrinsic allergical colitis to have a fever and to lose some weight, like moderate loss of weight or minimal loss of weight is common with extrinsic allergical colitis. So,
So
yeah.
again, borderline in
Mm-hmm.
the differential. The last, concerns and welfare.
Uh,
Did he address
what?
the concern well?
No, because I asked him, is it a cancer? He didn't mention like, is it a possibility or not? I
Yeah.
was waiting. You didn't like reply my concern clearly,
Yes.
because I didn't
Uh,
hear yes or no, or I will consider it or not. Mm-hmm.
Again, Dr. Mahmoud, for the serious form of the disease, you have to answer clear answer regarding the concern. And if you suspect cancer, put it. Tell to her honestly, doc. I guess you might have. It's one of the possibility, although it's not on the top. Because here there is weight loss, although no appetite change, but there is weight loss, significant weight loss. I think you didn't ask about how many kilo over how long, right?
I mentioned it to him, I think.
Okay.
Mm.
So you have to answer clearly regarding the concern. Smoking is there or ex-smoker, so
Yeah,
still he has
the
risk
risk.
for
Mm.
cancer. You can put it and you can tell him we will do some blood test as you did, scans to rule it out. It's not in the top, but we have to consider it as you are ex-smoker,
Mm.
and also there is loss of weight, some beta symptoms, right? Fever as well.
Yeah.
So I will give borderline in the concern the welfare, I guess it will be satisfactory.
Yes. He was very nice doctor, actually.
Okay. So this is
Thank you.
yeah.
You know,
Uh-huh.
I have also chest. Okay, doctor. Okay.
Chest case.
Yes, I have chest case, but it is for
Okay.
Dr. Basim. Sorry,
Mhm.
but it's very good case. But
Okay.
Dr. Nagla tell that she studied well.
Yes. I
Okay,
mentioned it
if
clearly, يا جماعة.
okay, if you need
Dr. Bassam,
Yes,
okay,
Dr.
Dr.
Azhar.
Azhar,
yeah,
Dr. Azhar.
I think Dr. Mahmood, he did very well. His exam is very near. He just needs only confidence. He is doing very well, very well. MashaAllah, only a little bit hesitance. And if he will make a good differential, like if the dry cough, simply he should
Yes.
consider around about chest, asthma, occupational chest,
Yes.
then along the chest there's a GERD, then medication like ACE inhibitors and post-nasal drip. Please don't forget post-nasal drip may also cause this dry cough. But in my opinion, he just only need confidence, and in the exam he will do very well, inshallah. I'm very hopeful.
Thank you, Dr.
Thank you, Dr. Azhar. Thank you.
Welcome.
But you know, Dr. Basim, I enter the case as it is cardiology, not pulmonology.
No. That's why the
Actually,
comments.
excluded the cardiology.
Yes, it is excluded.
Very
Yes.
good.
Nothing.
Yeah,
Nothing. Yeah,
you
she told you
excluded
So,
it
I
manually
sleep
from the start.
flat. Yeah, I know leg swelling. It
Yes.
was clear that chest case.
yes, so
I'm
I
lying
replaced
flat,
after.
sleeping flat. You asked all the cardiology questions and you excluded very well at the start. I just
I
wanted.
can.
Mhm.
Yeah. Add, Dr. Najla. I want to comment after your.
It's
Okay, go
okay.
ahead.
It's okay.
Yeah, regarding the point of confidence, I feel Dr. Mahmoud was so confident. I think so, but he didn't use the weapon he got from the case, and he didn't put good differential before starting. That's why he was lost. If you put in any long course, short of breath and cough asthma, you will have good mark. Okay, so asthma, one of the important, even the contact with animal you didn't ask. When she asked you, when she told you only I am reconstructing a farm, only that time you ask about. But asthma or pet or reconstruction or any painting outside related to your house, all this question is very important in short of breath case.
Did you move house? Did you move from the
Yes.
area where you live? Any allergens around you? You can ask those questions as well.
Okay, you can say what you want to say
I
earlier.
wanted to run through the investigations and what you are expecting in it. So we'll do the routine investigations. We'll do full blood count. We'll searching for eosinophilia.
Exactly, and the bell you mean.
Yes, and the extrinsic allergical colitis patients always have high ASR. We need to do ABG as well because this patient had saturation of 93% as a baseline. So we need to do ABG as well. The chest X-ray is very important. I don't think you mentioned it, Dr. Basim.
He mentioned high resolution
CT.
CT chest.
Yes,
Yeah,
you mentioned CT
but
straight away.
always start by chest X-ray.
Chest X-ray, yes.
Yes.
And in the pulmonary function test, what
You have to say what's the expectation.
Yes, what you expect in the pulmonary function test? Do you want to answer this? So we'll see the restrictive pattern of fibrosis, and
Yes.
the gas transfer will be high or low?
Trans factor, yes. Co-transfer factor. Yes, Dr. Mahmoud, you can answer.
Yeah.
Low.
Low,
Yes,
yes,
Dr.
it will
Basim.
be
Yes,
low.
fibrosis.
Yeah.
Perfect.
Yes, and you did the bronchoalveolar lavage, which is very good. It's important in this condition, and we expect to find lymphocytosis and mast cells.
Yeah.
In it. Okay. And the treatment in the acute phase, it's better to be like divided into acute and chronic. In the acute phase, like removing the allergen is very important. I mean, like not going to the farm is very important. You may need to give oxygen if the patient saturation is very low, but 93 might be his basal, so no need in oxygen for this patient. Short course of prednisolone, lowering dose in the acute phase will be very important. And then in the chronic phase, we need to avoid exposure to the allergen, because continuous exposure to allergens may lead to bronchiolitis obliterans as a complication. There is option of wearing face mask or even helmet if he insists to continue on his job. And extrinsic allergic alveolitis can be treated by long-term steroids, and you may consider steroid-sparing medications if the condition is ongoing. Yeah.
What
That's all.
do you expect in the high resolution CT?
Yes.
You will find the fibrosis. He answered it the right
Yeah,
way. Yeah,
reticulonodular.
the nodular shadowing. Yeah,
Early.
with the
This is
adequate.
early stage. Yeah.
Yes.
What's in the about the last late stage, Dr. Mahmoud?
DD, differential diagnosis.
Hmm?
Differential diagnosis. Differential
No, no.
no,
The
ask.
late,
Yes.
the late stage and the high resolution CT chest. What you might find. Yes.
Honeycomb
Honeycombing,
appearance.
yeah.
Honeycomb appearance.
Okay, perfect. Okay, what else in the examination, Dr. Mahmoud, you miss related to chronic fibrosis?
Dr. Basim,
Mhm.
in high resolution CT, you can divide it into non-fibrotic or fibrotic, because sometimes the hypersensitivity pneumonitis can come without fibrosis. So if it is non-fibrotic, you can expect the ground glass appearance in the CT. And in fibrotic, as she said, basal
honeycombing.
sparing, basal sparing or scattered fibrosis.
Mhm. Okay. Thank you, doctor. This is regarding the high resolution CT chest finding. I asked about the finding in examination. What else you have to do, Dr. Mahmoud, in chronic fibrotic lungs?
Bronchial breathing.
No, it's related to the cardio, as you said.
B2.
Yeah, B2 and
heaviness, RV.
yeah, parasternal here.
Yes. Yes.
Always remember, any lung disease, you have to do pulmonary hypertension signs and finding in the examination, okay?
Yes, doctor.
And the lymph node, please, it's very important. Any infectious disease you have to do, even it's negative, you have to act like I am trying to pick up any lymphadenopathy. Patient is chronic infectious, for example. I might have any lymph node enlargement. You start by cervical, you can offer axillary. And finally, if you have GI, you can offer the inguinal. Don't miss the lymph node. It's very important, okay?
Okay, Dr. Basim.
Okay, and the clubbing also you try to pick up, and the nicotine staining in chronic smoker, you have also those to offer. Raise GVP as well for heart failure, right side. Yes, I guess this is the case. Anyone want to add comments about the case, about Dr. Mahmoud performance? It's okay. Dr. Najla, you want to add before receiving
DD, Dr. Naglama, sorry, differential
the
diagnosis.
So
differential diagnosis?
extrinsic allergic alveolitis in the top of the list, then occupational asthma, then you can put allergic bronchopulmonary tuberculosis, as you mentioned, and you can put lung cancer in the bottom of the list.
Okay.
Yeah, and you know the difference between, it's very important. We mentioned it in a session before. Extrinsic allergic alveolitis always a differential to bronchoalveolar
Allergic
allergic
bronchopulmonary
bronchopulmonary
tuberculosis.
aspergillosis. Yeah, ABBA.
Yeah.
Always they are, and the difference is clear. The extrinsic allergic alveolitis is fibrotic lung disease, and allergic bronchopulmonary aspergillosis is obstructive lung disease.
Yeah.
On top of asthma, the patient ABBA will be with background of asthma, and he will be complicated with the bronchiectasis change. So it's asthma complicated by bronchiectasis. This is the ABBA, and the extrinsic allergic alveolitis. It's fibrotic pictures more than the obstructive. complication, I mean. You got it, Dr. Mahmoud?
Yes, Dr. Basim. Yes.
And both of them may be related to the farm.
Yes, yeah.
Okay.
Okay. One of them is the farmer lung, which is Abba, right? Or the opposite. I think the allergic bronchopulmonary aspergillosis is the farmer lung.
Yes. The extrinsic allergic, I think the farmer lungs. I'm not
Yes,
quite
yeah,
sure.
the Fancier, yes, the Fancier, yeah. The
Fancier
products,
is for
yeah,
aspergillosis.
yeah, yeah. So the products of any for birds.
Birds, yes. So it's valid to ask me any contact with birds as well.
Yes. He asked instead sheep and cattle, which is related to brucellosis, because you put in your mind a brucellosis a differential. That's why you related the condition to the cattle only and sheep. But you have to ask any animal, not only cattle and sheep. The bird itself is one of the trigger, or the bird products as farmer lung, which is the condition here. Anyway, we are learning, Dr. Mahmoud. However, you didn't
Excuse
get.
me.
Yes.
What do you think about stopping the patient from doing his work in the farm?
I mean, yeah, this is the best answer to address his problem, because it's something like hobby. It's not financial supportive job. So he can stop it. If I am the one in the position, I will tell him, please, you can do other hobby or you can use precautions, but it's better to avoid it because his lung will be destroyed by these products, and he has other options to do. If hobbies, for example, he can do something else.
Yes, and I read here in Up to Date that the disease might improve even if the exposure continues. So it is not a sharp thing. You can just consult the patient about changing his work in the farm. If he insisted, if he insisted, you can just tell him, as Dr. Najla mentioned, very nice thing, that equipment to avoid exposure.
Yeah, the precaution, you mean, yes.
Yeah, yes. There is option of precautions, yeah, but the continuation to be exposed to the allergen might hazard his lung.
Exactly.
He already started to have shortness of breathing at rest, so he must cut this ongoing exposure to allergen. So I'm not quite sure, but I don't believe extensive allergic alveolitis will get better anyway if the patient continue to be exposed to the allergens the same way without precautions.
And that's why he must, or better to stop
Yeah.
this exposure as a trigger, because it's type of allergy, doctor.
Yes, it's directly related to the allergen.
Yeah, so it's, yeah, and it's allergic. I think type 4 allergic reaction. So whatever he stopped, the reaction will be better.
It is reversible fibrosis, by the way. Reversible.
Early stage.
Yeah, in early stage it's reversible.
So he has, I think, better to advise him to find another activity or something to do different than this farm.
You mentioned it's private. I'm not quite sure, Dr. Basim, but I believe he must have a say. I mean, this is a say of occupational health team. I don't know how he can approach them, but I believe this is the area which the occupational health team can work in, like advising the patient about the precautions and how to avoid allergen and such things. But I don't know about the logistics of how to approach them. I'm not quite sure.
Yeah, what I know, the occupational or social, they are concerned about the government or job and the financial support. But I think he's doing this like hobby. So what the job, or what the action of this team in his private hobby, which is
Even
something.
I believe in the hospital he can get access to occupational team. I'm not quite sure.
No. I think he said that he's a constructor in the farm, right? So this is
Yeah.
private hospital.
He's doing
Yes.
he's doing
Yes.
his own business or his
So
own
I think they will
after
have
retiring.
health insurance, so they can ask the occupational health in the in the
Yes.
private health insurance, because this is an occupational disease as
Yes.
asbestosis, and he might also ask for compensation.
Even for his own?
But this is a private job, so he
He's
will have.
doing he's constructing his own farm. His
I
own
think
farm.
also yes, he has. All people here in the UK have
Okay.
health insurance.
Yes, yeah.
Maybe, yeah,
With
different
NHS,
system, yes.
with NHS, all people, everyone in the UK, even if they are not have the nationality, they have insurance under the NHS, health insurance. So I think, but there is not. I think some people saying that the occupational health in the hospital. No, any occupational disease, occupational health, but not in the hospital, in the company. The occupational health in the hospital only for the stuff, for the needle prick, for all these things.
Yeah.
So you can say we can ask your manager to refer you to the occupational health team like this, but not, we are not referring to the occupational health in the hospital. The occupational health in the hospital is responsible
For
for
the-
medical stuff.
For the stuff, yes.
Yes.
Thank you, Dr. Sarah. Any other comment, please, for others? From others, any question?
I said about the brucellosis, it's not a differential brucellosis at all.
Yeah.
Yes.
I agree too.
Yes.
Okay. Yeah, Dr. Sarah add also ABG, Dr. Mahmoud. Remember the bedside test for every station.
I think his oxygen is 93.
Yes.
So here in the UK, when we do the EBG to check for CO2 retention,
Yes.
so we give the patient the target, not as the normal target till 95. But if the patient has CO2 retention, the target will be from 88 to 95. So this patient, we don't have proof that he's retaining oxygen or anything. That's why, as his
Yes.
oxygen saturation is 93, we should do an EBG for him to check.
Not
Yeah.
only for this, Dr. Sarah, any chest complaint,
Yeah,
you
he
should
needs to be
offer it.
able to.
Yes, and I think he need oxygen also because 93.
Yes, he can offer oxygen and he
Yes.
can say ABCD if the patient in the acute state
Okay.
and short of breath. And the chart always, Dr. Mahmoud, whenever you see saturation less than 94, which is abnormal, you have to think about offering oxygen and to mention the ABG in the initial management steps. Okay.
By the way, COPD can go in the bottom of the list as well, for the differential because he used to be smoker. Although the cough is not typical for COPD, and no wheeze, but it can go in the bottom of the list.
Yeah, agree. COPD and the asthma,
COPD, yeah.
both of them are differential to each other. Whatever you
Yes.
mention, the asthma, you can mention the COPD. Whatever you mention the COPD, and whenever you mention the COPD, you can mention the asthma as differential. Since the patient is smoker, of course. Okay, any comments? Should
No,
we
yes.
admit this patient? Who want to comment, please?
I think yes, because the oxygen is 93. Till prove otherwise. Till will be proved that his normal oxygen from 88.
Yes.
So he
Not
should
only
be
this,
admitted.
and also the short of breath while resting. This is indication for. I think this patient in the advanced stage of fibrosis to have hypoxia in this extent or the short of breath while resting. It's very advanced to have this short of breath, right? It's not with exercise only. It's with even with the rest.
Even at rest, yeah.
Yeah. Please, the differential, Dr. Tabassum ask. Okay, so again, asthma or either occupational or asthma disease itself, bronchial asthma, and the case here, extrinsic allergic alveolitis. Okay, these are the three. I mean, three of them: extrinsic allergic alveolitis, asthma, bronchial asthma, and occupational asthma. And you can put COPD as the patient is smoker. These are the four differential. Brucellosis shouldn't be in this year, Dr. Sarah. Differential, it causes pneumonia, consolidation, abscess, nodule. Okay, Mr. Sam, yes, your case here, Dr. Najla,
Where I
35.
can see it? Where?
I will send it again, no problem.
Okay.
Mr. Sami, 35-year, complain of headache, not responding to any analgesic. Please take history and address any concern. Okay, I will send it now again to the chat box.
Okay, I saw it now. Thank you.
No, I'll send it again. Anyone has comment? Tell Dr. Najla will be ready. Yes, please.
Is Dr. Basim admit this patient? We will admit this patient or not?
Yes, the severity
Admission.
severity of short of breath is important here.
Okay.
Severity of short of breath while resting, I think even the cardiac station, it's something to get attention for it, right? Short of breath in rest or at rest. Right, Dr. Mahmoud?
Yes, Dr. Basim, thank you.
The vital chart, Dr. Mahmoud, is very important in any long scenario. In clinical scenario, it might be a clue for you. You have to read carefully the vitals. Saturation low, so you have to think about something serious, not only chest disease, no, something also serious. And it give you a clue to start with ABG, to give her oxygen while talking to her. If you feel her or him dyspneic, you can offer oxygen. These things will give you good mark in the clinical judgment as well as the welfare. Okay.
Okay, Dr. Basim.
Blood pressure high, also put it as initial assessment, like you have to comment on this and this. Or at the end, when you say the vital, you can tell him, is it high like what's written in the scenario outside? You will give the examiner impression that you are taking care of the vitals, even from outside. The fever, sometimes the fever will be outside 39, but when you check the temperature of the patient inside, you will ask him how much is the temperature, he will tell you normal. What about the temperature high or the high temperature outside? Means what? He took paracetamol, he was febrile before, so the grade of fever also is very important to put a differential. Okay?
I'm
Okay,
ready.
doctor.
I'm ready to go.
Yeah, okay. Here you go.
Hello.
Hello?
Hi, I'm Dr. Siddiq. I'm one of the doctors covering today. May I confirm that you are Mr. Sami, 35 years old?
Yes, doctor.
Yes. Hi, Mr. Sami. Hi. I'm here to discuss about your condition. I may need to examine you and answer all your concerns or questions. Is that okay with you?
Sure, doctor. Sure.
Okay. So, Mr. Sami, can you please tell me what brought you here today?
Yes, doctor. Since today morning, I have headache, severe headache, doctor. I think it is the worst headache that I have ever. Yes.
Sorry, Mr. Sami.
Thank you, doctor.
So it is only today. You have never had such a headache before?
No, doctor. I have a headache since I think 6 months or 1 year. But with painkiller, I can improve. Now, doctor, today morning headache is very, very bad. Really, very bad.
I'm really sorry for that. So if I,
Thank
in
you,
a scale of 0 to 10, 0 being no headache and 10 being the worst headache you have ever had.
10, doctor.
10. Okay. Can you just describe the headache? Where is it in your head?
All over my head, doctor, I think.
All over. Any neck pain?
No, doctor.
Okay. And do you feel what makes this headache? What makes it worse?
Really, doctor, I don't notice.
Okay. Did you notice anything?
It is worse.
So did you notice anything makes it better?
No, doctor. No.
Okay. Changing your position, do you feel like it's changed the headache?
No, doctor. No.
No. Okay. I'm really sorry, Mr. Sami. Are you
Thank you,
okay now,
doctor.
or you would like me to give you some pain medication?
No, doctor. I taken paracetamol. Thank you very much.
Okay. Okay, that's good. So you are okay to continue?
Yes, doctor. Thank you very much. Yes.
Yeah. Okay. So, Mr. Sami, do you have any dizziness?
Today or
Now, yeah,
yes, doctor, I feel dizzy
you feel
all the
dizzy.
time. Yes.
Yeah. And what about your vision?
Yes, doctor, I have severe blurring vision. Yes, you are
Blurry
right.
vision.
Yes, doctor.
It's just only today.
Yes, doctor. Yes.
Any weakness in your body?
Weakness? No, doctor.
No. Any numbness or abnormal sensation in any part of your body?
No, doctor, I don't think so.
No. Okay. I'm really sorry, Mr. Sami. So, okay. So, do you have any difficulty walking?
No, doctor. No.
No. Okay. Okay. So, Mr. Sami, I would like to ask you some general questions before examining you.
Thank you, doctor.
Yeah. Are you known to have any medical condition before?
No, doctor. No.
No.
Never.
Okay. Have you ever has any issues with your blood pressure?
No, doctor. No, never.
No. Okay. Do you have any problems in you in your urine? I mean,
Water
in your
work?
water work. Yeah. Do you have
Yes,
blocked
doctor.
urine?
No, doctor. No.
Any change in the urine color?
No, doctor. No.
Any pain in the sides of your tummy?
No, doctor. No.
You have you okay. So you don't have any issues in your water work?
No, doctor. No.
No. Okay. Do you have any family history of kidney problems?
No, doctor. Yes, doctor. My mother died due to kidney failure.
I'm really sorry for what happened to your mother. No one else other than your mother having any kidney issues?
I think, doctor, my father has a stroke.
Had a stroke, okay.
Yes, had a stroke, yes.
Okay, sorry for that.
Thank you, doctor.
Okay, so Mr. Sami, just a couple of general questions. How's your appetite?
Good, doctor. No
Okay.
change.
Okay,
Yes.
no issues with your tummy?
No, doctor.
Any bowel problems?
No, doctor. No.
Okay, do you have a cough or chest pain?
No, doctor. No.
Do you feel any heart racing?
No.
Okay, and any lower limbs swelling or pain or heaviness?
No, doctor. No.
No, doctor. Okay, okay. Okay. Thank you, Mr. Sami. I would like to examine you, but while examining you, I may ask you some questions. Is that okay with you?
Okay, doctor. Sure.
Yeah. Okay. So I would like to start my examination by the cranial nerves. Do you have any
Okay.
issues? Yeah, any issues with smell?
No, doctor.
You mentioned your vision is blurry. Can you explain more?
Yes. Okay, doctor. Today morning, I have blurring vision. I don't know why, really.
Do you feel like there is part of your vision you can't see
No, doctor. It's like dizziness. Maybe due to
Yes.
headache. I don't know, doctor. Yes.
Okay. So I would start with the field of vision.
Yes.
Any field defect?
Yes. Bitemporal defect.
Okay. Okay. And what about eye movement? The H-shape eye movement? Normal. Okay. Good. And I would like to do fundoscopy.
No need.
Okay. So I will move to the facial nerve. Any affection in the facial nerve?
Facial nerve, no, doctor. No.
No. Okay. Can you please protrude your tongue? Any deviation?
No, doctor. No.
Okay. Can you shrug your shoulders? Any abnormality?
No. Yes, I know. No, normal, doctor.
Normal. Okay. I would like to check the vital signs. Blood pressure.
119 over 70.
Pulse rate.
Pulse rate 80.
80. Regular and synchronized.
Yes.
Okay. And okay, I will go to examine the abdomen.
Yes.
Superficial palpation,
Normal.
deep palpation, liver, spleen,
Normal.
kidneys,
Normal.
normal. No
Yes.
palatable kidneys.
No.
No. Okay. I will go to lower limbs. Any
Normal.
edema, normal. Okay. Back to the chest. I would like to listen to the chest. And
Okay.
is it any abnormality in the chest?
No normal.
No. And the heart sounds?
Normal.
Okay, good. So, Mr. Sami, can you please tell me what do you do for living?
I'm accountant.
Accountant.
Yes.
And have you mentioned that you had headaches on and off for the last 6 months. Can you explain more? How frequent you had it?
Yes, it is continuous, doctor. I think every day I have headache, but
Yeah.
but it was responding well to painkiller.
Are you known to have migraine?
No, doctor, no.
No. And the headache, is it every day?
Yes, doctor.
Was it every day?
Usually every day, yes.
Yeah.
Usually.
Is it in the morning?
No,
Or
doctor. No.
does it awake you from sleeping ever?
No, doctor, I don't think so.
No. Is your job stressful?
No, doctor. No, I am a
Happy?
manager.
Eh,
Yes.
yeah. Okay, that's good. You don't feel any stresses at job,
Never, doctor.
even at home?
Even at home, doctor.
Okay, that's good. So, Mr. Sami, what is your concern?
Yes, doctor, what I have. Is it a stroke like my father?
I appreciate your concern, Mr. Sami. From from what you said to me and your examination, I don't think it is a stroke, but it's a valid concern, and we need to do imaging to exclude it. But I can put it on the bottom of my list, but I'm suspecting you to have a condition called subarachnoid hemorrhage. Have you ever heard about this?
No, doctor.
So it's actually, don't bother yourself about the long medical term. We can call it SAH for short. So it is basically a bleeding in your brain, in the back of your brain, and it's characteristically causing this severe headache. I would like to admit you to the hospital to keep you with us for some time. I would like to request a brain scan for you now immediately, to be done as soon as possible, and we will check for the scan, if there is any bleeding, it will occur, but if the bleeding is minimal, it might not show in the scan. So we'll need to keep you in the hospital for some time, and we may need to take some blood, some water from your back. Are you following me, Mr. Sami?
Yes, doctor, yes.
Yeah. So yes. Otherwise, I would like to do routine bloods for you, just routine investigations, and we will keep you under follow-up. Before that, are you taking any medications, Mr. Sami?
No, doctor, no.
Yeah, because before doing the procedure, we need to make sure that you are not taking any medications that affect the blood thinning. Just wanted to make sure. So, do you have any other questions or concerns?
Thank you, doctor, very much.
You're welcome, Mr. Sami. Do we have more
Still
time?
4 minutes.
4 minutes.
Yes.
Okay.
Any social any
Yeah. So, Mr. Sami,
anything?
how this affects your life?
Yes, doctor, affecting me much, doctor. Yes.
Can you explain more?
Yes, doctor. Yes, I have a problem, doctor, in intimate relationship. So it is a big problem also for me. Yes.
Yeah. Can you explain more? What do you mean?
Yes, doctor. I married since 2 years. Until now, no children.
Okay, Mr. Sami.
Yes,
I'm
doctor.
really sorry for that. So and Okay, so did you contacted any doctor, or did you have any diagnosis regarding this issue?
Yes, doctor, I tried many medication, but not improve, doctor. Yes.
Okay, so I would like to check on the patient's general critique. Is he taller than usual?
Okay, doctor, thank you.
Are you tall? What is your
No.
BMI?
No, doctor, normal, doctor.
Okay, okay. Okay, Mr. Sami. Regarding this issue, I believe we can discuss it with
Okay, is it
with the
relation
glands
between
doctor.
impotence? Okay.
Yeah,
Is relation between impotence and this headache?
headache. Do you feel like there is a relation? Is it related to your headache?
No.
No.
I don't know,
2
doctor.
minutes left.
Okay.
Tell me.
So you can involve the glands doctor, and who can just take this further and discuss it with you and do further investigations.
Okay, doctor.
Yeah. Okay, I can give you some leaflets to read about the subarachnoid hemorrhage and
Okay, if you have
the plan of
1.5 minute, Dr. Najla, what examination you want to do else? Related to the intimacy and headache.
Intimate.
Yeah.
Okay, so I will consider having pituitary issue. So I can do like checking on the palmar crease. Is it darker than usual?
No, doctor.
And the blood pressure sitting and standing.
Yes, it is change. Yes.
There is significant change.
Yes, doctor.
Okay. Because you mentioned the patient mentioned blurring of vision just started with headache, or do you have
today. Yes, today only,
Yes, only
Doctor Nash.
yesterday only, but you didn't have to have blurry vision before.
No, doctor. Just today.
Okay. Having bitemporal hemanopia also might direct me to pituitary. So the field of vision, there is bitemporal hemanopia, which might direct me to the optic chiasm tumor. But the headache is not like the brain tumor headache. It's just during the day. It's not awaking him. It's not first thing in the morning, not awaking him from sleep.
Just since morning, yes.
Yeah. So yes, I would like to do.
Okay, time is up.
Okay.
Okay, tell doctor what's your diagnosis?
My diagnosis, I'm suspecting this gentleman to have a subarachnoid hemorrhage. With this diagnosis, is the character of the headache is like the worst headache ever, and it is just only today morning, and supported also with the family history of stroke and renal problem in his parents.
Okay, renal problem of what? Do you ask him
parents?
what is the renal problem of this patient?
Renal failure you mentioned in the
yes,
in
it is renal failure due to what?
His parents.
Yes, due to what?
I suspected adult polycystic kidney disease, but in the examination,
my mother lupus, not polycystic. Okay, go on, Dr. Nash.
Okay.
Mother, if you asked me, I will tell you lupus.
You mentioned your mother had the renal failure.
Yes, renal failure. He is on dialysis.
Yes.
But what is the cause?
Okay, I didn't ask about this. Sorry.
Yes, doctor.
And I would suspect again pituitary problem, pituitary apoplexy maybe, or hemorrhage because of bitemporal hemanopia feature of, or pituitary adenoma as well because of bitemporal hemanopia in his field of vision. But again, it's this history of headache, the sudden nature. Although he had headaches before, but I couldn't relate it to any brain tumor, like the nature of the headache, how it comes.
Okay. Okay, doctor. What is the relation between patient has intimate relationship and also headache?
The pituitary tumor can explain it, or pituitary hemorrhage can explain it.
Yes. What type of pituitary?
What type of pituitary adenoma you mean? Yeah.
Yes. Okay, Dr. Nash. Yes. Okay, very good. What is investigation to this patient? What will you do?
I would like to do CT now, and I may consider to do lumbar puncture if the CT didn't show any hemorrhage, and I might consider doing MRI to check for the pituitary.
Yes, Dr. Najla. Okay. So what is the treatment of this patient?
Treatment. If he got subarachnoid hemorrhage, I would like to consult the neurosurgeons for it's according to the how much bleeding he had. He might need surgical intervention, but if it is a mild bleed, it might be subsided or absorbed by itself. Regarding the pituitary tumors, again, I would like to consult a neurosurgeon. So the management of this patient should include a multidisciplinary team with neurosurgeons and neurology doctors as well, specialized nurses and social workers and occupational health team as well.
Okay, doctor. Okay, sorry. What investigation for subarachnoid?
I will do CT, and if the CT is clear, I would like to do lumbar puncture after 12 hours.
Okay, what else?
What else?
MRA.
Yes, I can do MRI as well.
Okay. What will you find if the patient has subarachnoid hemorrhage? What will in the neck of the patient?
Neck.
Neck stiffness. Yes.
Yes.
If the patient has neck stiffness.
I didn't examine his neck actually.
Mm-hmm.
I asked him if he had neck pain in his history, but I didn't examine his neck. No.
Don't trust the patient.
Yeah, I need to check it. Yeah.
I am big layer. Okay.
Mm-hmm.
Okay, doctor. Okay, Dr. Najla. Well done. Okay. What will you find in LB of subarachnoid hemorrhage?
LB. So I will find xanthochromia from the start. Just one. So xanthochromia and
Yes.
yes, and the blood cells in the microscope. I will comment on it.
Okay, and lymphocytosis. Okay, Dr. Najla. Well done. But the patient has prolactinoma and then developed pituitary apoplexy. Okay. I put the patient family history of his mother has renal failure. It is tricky. Patient mother on dialysis. What is the cause? It is not polycystic kidney. And also the examination, the patient has no renal pain or like that. Patient also has no stiffness. Patient has severe headache. It is the worst headache that he have. So we will put our differential diagnosis for sure subarachnoid hemorrhage, but patient has a problem in his intimate relationship and has discharge also from his nipple. So this patient has prolactinoma and developed then pituitary apoplexy today. What do you think? So?
Yeah.
Yes.
Yeah. Yes.
Let's start marking.
Yes, it is. It is.
Actually, yeah. It makes sense now, but
Yes.
yeah, but the headache it was tricky. The history of headache because with prolactinoma, I believe it might be like a like it might show some of the features like early morning headaches or
Yes, today it is acute headache. Yes.
today, yes.
Yes,
And
today.
the eye issues, the vision issue, like the field of vision, supposed to be like
Yes, today. Yes, today he
all
has,
today. Okay.
and also today patient has dizziness, so it started affect the all pituitary gland. So it is pituitary apoplexy.
Okay, thank you.
Okay.
Okay.
Well done, Dr.
Well done,
Najla.
Dr. Najla. Don't worry.
Okay, let's mark for the physical examination. What?
Physical examination. Dr. Najla suspects subarachnoid, so it is a must to check the neck stiffness. And also didn't in the history didn't tell me about my intimate relationship, any discharge from the nipple, didn't check any pituitary, any thyroid, any signs in communication in history.
No, leave the history. I mean the physical examination.
Physical, it must examine the thyroid and also blood pressure setting and standing. Asked me later. Okay.
Why thyroid here, Dr. Mahmoud?
It is hypopituitarism, Dr. Basim.
Okay.
Pituitary apoplexy, but it's just
yeah, the thyroid
check.
itself will be clear. I mean,
yes, it will be
intact.
clear. Yes.
Okay. So let's say the CNS examination is much important, and the
CNS very good, very good.
And
very good examination.
The vision
and
is
the vision,
important.
yes,
all the steps, right?
Yes,
acuity.
Yes, very good.
Acuity, fields, and reflexes. And when you offer fundoscopy, Dr. Najla, you have to tell him what you want to check. Not only offer fundoscopy. I want to do fundoscopy to check for papilledema.
Yes, actually, yeah. I just surprised he mentioned no need. So yeah.
Yeah, he want to trap you. So you can tell I want to check for papilledema in the fundoscopy. He will tell you yes, there is, or no, according to his answer, whatever. But you have to offer it. It's one of the pathognomonic signs. So I think in the physical examination,
satisfactory, yes, doctor.
Satisfactory?
Yes, doctor. Yes, doctor. Yes.
Unsatisfactory, you mean?
No, satisfactory, Dr. Basim.
She didn't examine a lot of things, but I will give her
borderline.
Okay.
Okay. Neck stiffness, because Dr. Najla suspects subarachnoid.
Okay, so neck stiffness she didn't do. So how I give her satisfactory?
It is very important. Any acute headache is subarachnoid till proved otherwise.
Yes. Okay.
Okay, identify the findings. Did she identify any of the findings?
I'm sorry, Dr. Najla, no.
The bitemporal hemianopia, who identified it?
No, but
no.
The finding of nasal nipple discharge. Yes, it is
okay.
the hallmark.
I ask you want to examine something else?
Yes, it is most important in this patient. And the patient told you, I have problem in intimate relationship.
Yes. Yeah.
So again, let's say borderline if you didn't pick up any of these findings. Although it might be satisfactory, but yeah, this time I will give you borderline. What about clinical communication, Dr. Mahmoud?
Borderline, Dr. Basim, I think, because
I think so.
Also didn't told me anything about my intimate relationship, any nipple discharge.
And also the history, I think, it wasn't systematic.
Yes, yes.
Okay, so again, borderline. It might be also unsatisfactory, but for the first time, the clinical judgment.
Okay, what do you think, Dr. Basim?
She gave the diagnosis, Dr. Najla. You give the correct diagnosis.
Give the diagnosis, yes.
But even you didn't correlate with the underlying pathology, which was pituitary adenoma. You mentioned the apoplexy, but based on what? You have to mention the underlying pituitary adenoma. What was the adenoma? He gave you a history of intimate relationship difficulty. So something related to hormonal assay. You have to suspect prolactinoma or the other one, acromegaly, according to the underlying or macro adenoma and the pituitary, whatever the type. So you have to put one of your differential or one of the possible cause of the adenoma, either acromegaly or Cushing or prolactinoma or panhypopituitarism. What type of adenoma you have, right? You didn't give explanation why he had early headache. You didn't ask about the previous headache even.
Yes.
So I think, yeah, we can give borderline. Still, you didn't fulfill the criteria. differential, you give the differential well, but it wasn't with evidence base. You give it, I think, just
Yes, all differential was perfect. Subarachnoid and pituitary apoplexy.
yeah. So you can
But
give
it
here.
must you told me that due to prolactinoma. Yes.
Yeah. So again, borderline. It's what's called linked, right? Linked marking, because all of them related to each other. Concern. Did you address the concerns?
Yes, yes, doctor. She answered me about my concern. But Dr. Najla told me that I have hemorrhage, not.
Yeah, you are concerned about a stroke. Yeah.
Yes.
Mm-hmm.
It
Okay,
is
for
more
the welfare.
complicated than a stroke.
Yes.
Okay, the welfare. I will minus you by anyway because you didn't ask about driving.
Yes.
Yeah, I missed this point.
So the welfare. I will.
And the impact on my job, Dr. Basim, about the headache on my job.
I discussed with you about the impact.
Oh,
She
yes,
asked
yes.
you. She
Yes,
asked
yes,
you.
Dr. Basim. Yes, Dr. Najla.
But
Okay, so
I missed the driving, yeah, which is a fatal mistake for me. It's really fatal.
okay, this
Yes.
is your mark. You can learn from your mistakes how you can improve and what you can improve in the next time. I guess, Dr. Naila, the history was unsystematic. You have to ask in systematic way, better than this. This is my comment. I think this is first clinical with me, right? Clinical case with me. Systematic, you have to start from the CNS and analyze the headache well. You didn't analyze the headache well. You didn't analyze the serious form of the headache, which was here. See, you didn't ask about alarming signs and symptoms of headache. Leaning forward
Mm-hmm.
and blurring of vision, weakness in the body.
Mm-hmm.
These are the alarming or red flags for the severe headache or headache with increased intraocular pressure, right? Increasing with sneezing, coughing. You have to ask these questions. The severity you ask, which is good, about the scale of the pain from 0 to 10. And whenever you have more than 5 at the scale of the pain severity, you have to offer painkiller. You can tell him, do you need any painkiller right now? And offer it to him, right? Okay?
I think Dr. Basim, Dr. Najla confused when I tell her that my mother has kidney failure. So all in my head brain that I have subarachnoid hemorrhage. So
Yes, it's
it is
subarachnoid, but
yes,
for what reason?
it is just confused about that. Yes.
Okay, did you examine the abdomen to rule out polycystic kidney? You
Yes.
examined
Yes.
the kidney?
Yes. Examine.
The
Yes.
kidney, the kidney,
Yes.
the kidney.
I
Yes.
examined the kidney, yeah.
Yes, doctor.
Yeah,
I told
okay,
her
you
normal.
palpate the kidney.
Palpate the kidney.
Okay,
Yes.
I
yeah,
checked for palatable kidneys, and
okay.
I explored about the red flags of the headache awaking him from the morning. He mentioned no, and the any weakness or
No,
numbness.
the previous headache, Dr. Najla.
The previous ones. Oh,
It is
okay.
the same or differ from this headache?
Okay. Yeah, you are right. You mentioned that those ones was the previous ones were mild and respond well to
Yes, it's just
to
prolactinoma.
paracetamol.
It was just a prolactinoma. But now pituitary apoplexy. Yes.
Whenever you finish before the time, 3 or 4 minutes, Dr. Najla means something is defective, either the history or examination. And whenever you have severe headache, you suspect subarachnoid hemorrhage, remember always the neck stiffness, either meningitis or this patient subarachnoid hemorrhage. We mentioned before the causes of severe headache with increase in intracranial pressure: meningitis, subarachnoid hemorrhage, and cavernous sinus thrombosis, and stroke with massive infarction. In these cases, you have to examine the neck stiffness. Okay, and the meningitis, particularly, you can ask about Kernick sign and Bolzaniski sign, right? You have to know why the patient is having subarachnoid hemorrhage. Don't stick to what you think, which was polycystic kidney. However, it was negative. So find another reason. And he was volunteer to tell you I had intimacy difficulty. So you have to know why intimacy difficulty in this patient, either acromegaly or prolactinoma. Both of them can cause. So you can offer examination for the prolactinoma signs and symptoms. It's clear: bitemporal hemophilia, or enlargement, gynecomastia, I mean, or up to and milk discharge from the nipple, galactorrhea, right? Agree, Dr. Najla?
Yes, I do agree. Can you please, Dr. Basim, repeat the differential subarachnoid meningioma, meningitis, prolactinoma, acromegaly?
Yeah.
What else?
Cavernous sinus thrombosis
Okay.
and massive infarction or massive intracranial hemorrhage.
Yeah, okay.
And also idiopathic intracranial hypertension. It can cause increased intracranial pressure.
Yeah.
We mentioned it in the group. I will reshare it again. The headaches causes either with increased intracranial pressure or without increased intracranial pressure. I will write it again.
Okay, thank you.
Most welcome, Dr. Najla. Okay, you got the case and you learned today from this case.
Yes.
Yeah, you will never forget it again. It's it comes like this: patient with chronic headache, and suddenly he has severe headache, agonizing headache, which is the worst headache ever in his life. He will tell you, and it was the pathognomonic from the start. Dr. Mahmoud helped you in this. But what
Yes.
does the cause? You have to know the cause: either hypertension, uncontrolled hypertension, AV aneurysm, or subarachnoid hemorrhage due to perianeurysm in the polycystic kidney, or apoplexy, one of the possible cause. So you will know from the history, and also you will know from the examination. You have to know the reason behind this subarachnoid hemorrhage. Okay. Okay.
Yeah.
Now, if you want to add comment or to ask question, Dr. Najla, please go ahead.
No, I mean, regarding the investigations, we'll do the same. We'll start with CT and
Yeah,
then.
you did well and great. And you start with CT. You can wait 12 hours to do LP for xanthochromia, and if not there, you can do CT angio or MRA to rule out any aneurysm or bleeding in the brain. Okay, the lumbar puncture, as you said, for after 12 hours from the onset of the headache to do rule out of xanthochromia. Other investigation for the cause. So in this patient, you have to check prolactin level. It will be sky high, more than 4,000, right? Prolactinoma.
I think all hormonal
Yes, of course,
pituitary.
all hormones, but particularly prolactin, you have to mention it. Prolactin will be very high. Okay, significant high of prolactin level. Okay, Dr. Najla?
Yes, yeah. Okay.
Okay. Yeah, anyone, Dr. Mahmoud, you want to add comment or Dr.
Yes,
Najla?
impotence is very important in our structure. Very important in our structure. Yes. Thank you, Dr. Basim. Thank you, Dr. Najla.
Okay,
Thank you very much.
thank you.
Excuse me.
Yeah, sure, go ahead.
Okay, Dr. Najla, analyzing the headache, regardless of the case now, is very important because headache is most frequently coming in the basis exam. So regarding the analysis of the headache, I believe that you did not analyze the headache well. That's why maybe you missed the diagnosis.
Yeah.
As Dr. Basim told you, but I just want to revise with you the steps, memorize them and make them the most important homework today for you.
Yes, please do, because I'm
Yeah.
not, I didn't do a headache before,
You
so
were
I don't know even
hesitated.
the questions for analyzing headache. So if
Yeah,
you revise it,
you
it would be very nice.
yeah, you were very hesitated in taking the analysis of the headache. So you started very well. What brought you here in the clinic today? He told you that I have headache since morning, and the headache is the most severe headache I ever had. So the most important question and first question you ask if it is the first time or you have previous attack. Once anybody told you that I have previous attack, so you have to ask the patient, have you been investigated? Do you have any diagnosis? Did you take any treatment for the previous attack? Have you been investigated? any diagnosis, any treatment. He will tell you about this. Then you start with anything that the mentors would like to do, like Socrate, like. But the good thing that I like, sight and radiation together. Where is the site exactly of the headache, and it is radiated anywhere else, especially the neck. And then onset and trigger. Onset, is it sudden or gradual? Is this headache sudden or gradual? Then you ask him, is this headache the same headache you have previously, or it is different? And what do you think it brought you? It brought it to you today the same. Then the most important thing you did not ask, do you have any history of trauma? Head trauma? Because one of the causes of apoplexy is head trauma. Apoplexy also is bleeding. It is also bleeding. So is there any history of trauma? Okay. And then the nature of the headache, it is stabbing, aching, and then the severity. You jumped into the severity. The first thing, onset is important, sight is important, radiation triggers, and nature is important, and then severity. Then the course, is it increasing or decreasing or static? You asked about relieving factor and aggravating factor, but please, whenever you ask about relieving factors or aggravating factors, give example to the patient. Give example. Do you think that anything increase it? Like bending forward. Here you will touch the red flags. Sneezing, bending forward, or coughing. Do you think that anything that relieve it? Like, did you use any painkillers or rest? Or change in position in the aggravating factor? Then, like this, in aggravating factor, you will touch the red flags and you will not miss them. Then the timing. Which time during the day? Is it more severe in the morning or towards the end of the day? The thing that make you miss the diagnosis that he answered all over the day. If he specifically told you, I get up in the morning with this severe headache and it didn't improve throughout the day, this would be better answer. Then if he told you that it is a morning headache, that means that the headache will go away the rest of the day, Dr. Najla, because this is apoplexy, so the headache will be there. But he told you, I get up with this severe headache in the morning and it is continuous all over the day. Then immediately you take it as morning headache, because he did not tell you that I get up well and then the headache increased by the end of the day. Then you have to put in your mind, very important, like pituitary tumor or OSA. So you have to ask, is this headache associated with snoring at night? To exclude OSA. Is this headache associated with blurry vision and vomiting? To exclude pituitary tumors. Okay? What if he told you that the headache increasing by the end of the day? Then you have to think of the only one diagnosis in basis, which is anything increasing by the end of the day, headache, tiredness, anything increasing by myasthenia gravis. Then you have to do, like, I like Dr. Hussam, he's putting 8 Ds, dribbling of the eyelid, dropping of the dysphagia, dysphonia, dyspnea, difficulty swallowing, difficulty combing the hair, like this, leave it. Then, because you touched OSA and morning headache, and also you think of pituitary in this stage, because you asked very well about the onset of the headache and the duration, If you did not ask well about the onset and duration, you will not reach this point. Okay, so if you ask about, or if you think about OSA and pituitary, you will immediately ask about the intimate relationship. Both OSA and pituitary will cause problems in the intimate relationship. If he told you yes, then you have to analyze the type of blurry vision. The one mistake he did in the history, when you ask him, he said only blurry vision. In the examination, when you examine, you find bitemporal hemanopia. If you ask him, did you notice that you are bumping into objects in the home, cannot see the sides, cannot see the furniture in the sides, maybe he will ask you. And if you think of one diagnosis, don't just touch the question and go quickly. You raise your voice and repeat the question. But Dr. Ibrahim misled you, Mahmoud, sorry, he misled you by telling this it is just blurry vision.
Thank you very much.
Yeah.
But in examination, I told the hair bitemporal. I am a patient. Not he didn't tell me about what is the bleeding of vision.
Yeah.
He didn't decide.
Yes.
No. She should specify the question. Did you bump into the object?
Specify. I told her specify and raise your voice.
Yes.
Raise your voice, because in the history you already think of that because you asked.
By
about
the way,
onset and
it could be
duration.
also bleeding of vision due to papilledema now. So it might
Yes.
be papilledema related. But
Yeah.
doctor, you can make it by differential better than asking all causes. Like in this scenario, the patient is having increased intracranial pressure. So you can think about the causes of headache with increased intracranial pressure without going to the other. So OSA here is not the case. I will not ask about the OSA. I will ask
yeah,
about...
because I told her analyze the headache regardless of the case.
Okay,
and just revising with her how to analyze the headache whenever the headache come to you in any station, and then the answers of the patient will guide you.
Yeah,
okay?
Exactly. Yes, exactly.
Yeah.
I like your approach for headache, doctor. If you have more, you can, if you would like to continue, but it's really very good approach. Thank you.
Thank you. Thank you. I actually make the collection from Dr. Tan and Dr. Hussam. If you revise their sources, it will be very good. Dr. Tan is very good in differential. If you want to be perfect in the differential, Dr. Tan is very good. Dr. Hussam is very good in the approach.
If you have any like thing you want to share in the group, it would be nice.
Okay, we'll do, inshallah. Okay, thank you.
Okay, thank you, doctor. I wrote down the chat box, doctor, the cause of the headache in basis. So if you start by thinking about causes of increasing blood pressure, either acute onset or chronic onset, the acute onset will be meningitis, subacute hemorrhage, intracranial hemorrhage, massive stroke, cavernous sinus thrombosis, pituitary apoplex, and it will be chronic history, acute on top of chronic. I mean acute headache on top of chronic headache, which is pituitary adenoma. Then cerebral venous sinus thrombosis. These are the acute onset with increased blood pressure. The chronic onset with increased blood pressure as well. Space occupying lesion, brain abscess, pituitary adenoma, idiopathic intracranial hypertension. Let's go to the headache without increasing the blood pressure with acute onset, GCA, CO poisoning, hypertensive encephalopathy, glaucoma, and carotid dissection. In the chronic onset, you can think about, and this is also common scenarios in the basis, migraine, cluster, medication overuse, tension headache, and cocaine or illicit drug-induced pheochromocytoma, OSA, anemia, sinusitis, trigeminal neuralgia. These are the cases of headache and basis. We collected it and we did previous headache scenario in another session with another cause. So yes, if you want, you can search in the group. Just type headache in the group.
Oh, okay, I will do. If you just quickly, just how to identify the increase intracranial pressure in the history? Is it morning headache and vomiting?
Yes,
and
you can
change with
find
position,
feeling. You can find feeling sick, which is increased blood pressure sign. feeling sick or throwing up,
Mm-hmm.
headache while leaning forward, headache while sneezing or coughing, and bleeding of vision, and also neck stiffness or neck pain. These are the signs or red flags of increased intracranial pressure. You have to ask them in any headache scenario, or you can ask two of them. If you have negative two of them or three of them, so it's just headache without increased air pressure. Once you have one of them, you can ask another to confirm this is headache with increased air pressure. If you have it, you have to suspect the serious headache causes. I mentioned it in the message. You can review these causes, and according to the cause, you have to put yourself in the track of the cause of the either chronic headache with increased intracranial pressure or acute headache with increased intracranial pressure, or the opposite, acute without or chronic without. And always think about the differential better than taking the all causes and rolling them out and out, in or out. I mean, if you have acute headache with increased intracranial pressure, so it's easy to take the causes of acute headache with increased intracranial pressure and roll it out. Like meningitis, you have to roll out meningitis, either history of infection, history of sore throat, history of surgery, history of trauma to the head. This is in the meningitis. In the subarachnoid hemorrhage, you have to think about polycystic kidney. You have to think about any history of stroke in his father or mother for AV aneurysm, or for aneurysm for polycystic kidney. For AV malformation, you can find also history of AV malformation or stroke in the family. You will go to the pituitary apoplexy as a cause. You will ask also about the causes of pituitary apoplexy as a chronic headache, and you have to pick up the cause of the adenoma in this scenario. I think the venous side thrombosis also you can ask about OCP or history of clotting, or use birth control pills. For the massive stroke, you can ask also about previous clots. For the cavernous sinus thrombosis, you have infection in the face. It will be also the claw in the case. Okay, you have to do it one by one if you have the same causes of the same presentation. I mean, acute headache with increased air pressure. Uh, do this better than thinking in all causes. Make it categorized like acute without increase or acute with increase. It will be much easier. And
Yeah,
before you
it's
go
very helpful.
inside,
Yeah. Mm.
yeah, before you will go to the station, you have to write three differential, the commonest, and you can ask about them in the history taking. By the way, they will give you the duration of the headache before you go in, so you can put some causes related to the timing and the duration. Again, this message you can analyze and you can categorize what you have, the type of headache you have. Okay. Any other comment or a question, Dr. Najla?
Yes, Dr. Basim, in the main, يعني in the main scenario, he will not tell you, Dr. Najla, that I have a problem in intimate relationship. You should ask me, okay?
Exactly. I, to-
I
I told her, whenever you suspect apoplexy, you have to know what
to
was the previous adenoma. What
Mm.
type of adenoma
okay.
patient has? You have four types of adenoma, right? Let's repeat them. And the top and the most common is acromegaly. Then the
Prolactinoma.
prolactinoma, then Cushing, then panhypopituitarism. Or sorry, not panhan, it's non-functioning adenoma. Non-functioning adenoma in the form of
No.
panhypopituitarism. These
Yes.
are the four adenoma in basis and in adenoma and as general. So whatever you have to ask about what type of adenoma he has. Okay, every adenoma, you know the question for it. I mean, in the prolactinoma, you will have gynecomastia and discharge from the nipple. In the acromegaly, you have increased ring size or increase the feet size and increase the or coarse facial features. For the Cushing, the patient will have stria or stretch mark. He will have also easy bruises. This is for Cushing, and he will have also high blood pressure, high blood sugar. For the non-functioning adenoma, you will have hypothyroidism, you will have Addison, you will have also impotence. Okay, so every condition you have to ask about to pick up what the cause of adenoma in this patient. Clear, Dr. Najla and Dr. Mahmoud?
Sure, Dr. Bassem, sure. Thank you very much.
Okay, and you have to correlate it to the acute onset of headache after chronic headache. Acute on top of chronic, and the acute one very severe. Okay.
Yeah, thank you very much.
Okay, most welcome, Dr. Najla. Any other comment from others, please? Any question, any comment, please feel free to add.
Dr. Mahanna is still driving it now.
Okay, stay safe, Dr. Mohanna.
Just 1 minute regarding driving. What is it will be the advice in this case?
What do you think, patient with subarachnoid?
He's supposed to stop driving, but the timing I'm not.
Yes, until the resolve of his condition. So if this patient, for example, first of all, you will admit him. The severity
Yes.
of the pain will
Yeah.
let you admit this patient,
Wait
right?
for admission. Yeah, and immediate
Yeah,
investigation.
admission, and you will stop driving until we will update you when to resume it.
Okay, subarachnoid hemorrhage. How long they will, if proved subarachnoid?
Minimum time or duration to stop driving at least 1 month. Okay. Then after 1 month, he will be reassessed if he's able to drive, if he has any functional or cognitive or weakness or any residual, any vision problem. You have to reassess him. If he has any of these, he has to inform the DVLA. Yeah.
Okay.
Okay. But any answer related to driving in any acute, please stop driving until other further assessment.
Yeah, I'm asking about. Yeah, I got your point. But
Minimum
I'm asking.
1 month. It will not be less than 1 month. This condition, by the way, it's very serious condition. Subarachnoid hemorrhage. Patient might be in the ICU, and he might have also coma. He might be complicated with subarachnoid hemorrhage complication like vasospasm, like rebleeding, or whatsoever. So it's very serious condition. And also to regain his hormonal function, he should start on hormonal replacement according to the defective hormone after the apoplexy, because the apoplexy means bleeding into the pituitary adenoma or pre-existing adenoma, either bleeding or infarction, but mostly it's bleeding because of the high pressure. So he will be in failure, I mean pituitary failure or panhypopituitarism mostly after this event. Okay? Clear now, Dr. Najla?
Yes.
Okay.
Thank you very much, doctor.
Most welcome. Any other comment or any other question? Any question, Dr. Azhar? Any comment? Dr. Sarah? Dr. Sarah Ghanem? I think there is a lot of comments in this patient, or at least concerns, or at least question. Anyone, please?
Dr. Najla, think of meningitis, but she never asked about fever, high temperature. This is also worth mentioning.
Yes.
Yeah. Or
Yes.
She didn't ask about all B symptoms, which is very important in any scenario in the PACEL. You have to ask about loss of weight or loss of appetite, high body temperature, night sweats, and lumps or bumps. Whatever the scenario, it might be chronic
this is
scenario.
fixed.
Yeah, it could be a chronic scenario, but one finding of these, it might make convert the case as cancer or something serious like chronic infection with simple presentation, like for example cough, patient present with cough, and when you ask this question you found the patient is losing weight, no appetite, night sweats, night body temperature, so you'll think about TB definitely. Okay, even he came with complaint of cough, and you will find also the other finding like he's coughing up blood and short of breath, fibrosis signs, blood from the mouth, I mean, sometimes the clue will be in the constitutional symptoms. You have to ask about them in every scenario. Okay, Dr. Najla? Thank you, Doctor, also for your comment. Okay, Dr. Sarah said thank you. Thanks, Dr. Sarah, as well. Any question, any comment, Dr. Azhar? Anyone? Dr. Mahanna, please. Dr. Ahmed Hassan. Good activity by Dr. Ahmed in the evening. Keep it up and continue, carry on in this. I'm trying really to join your session at the evening time, but sometimes I am at work or busy. But please carry on. Whenever I am free, I will join you. I know this time is late for you, but whenever you can enter session, I will try to join. Okay? Any other comment or question before ending the session? Okay, thank you, Dr. Najla, Dr. Mahmoud.
Thank you, Dr. Basim. Thank you, Dr. Najla.
Thank you very much. Thanks a lot.
Thank you.
Okay, see you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.